I'm Dr. Riley.
And I'm Dr. Cook.
And today we're going to be talking specifically about ankle injuries. So in review, we have our general approach to the ankle x-ray, similar to all our orthopedic films, starting with adequacy and alignment, B for bones, C for cartilage and joint spaces, and lastly, soft tissues. Next, let's review our AP, our mortise view, and our lateral. These are all of the views that are necessary when obtaining an ankle trauma series or ankle series in general. Our AP is on the left. Our mortise, we're going to have our ankle in 15 to 20 degrees of internal rotation to open up that lateral clear space a little bit more than the AP. And if you have an adequate space around the entire mortise or ankle joint, then that is an adequate mortise view. And the lateral, which should have the plafond or the bottom of the tibia well aligned with the dome of the talus. And don't forget about a really important thing, which we're going to harp on in this lecture. This is the syndesmosis. Here are 3 parts of the syndesmosis that we outline out of the 5 that we find are the most important: the intraosseous membrane. Next is our anterior-inferior tibiofibular ligament, or AITFL, or anterior syndesmosis. And then lastly, behind here is the posterior-inferior tibiofibular ligament, or PITIFL, otherwise known as the posterior syndesmosis.
And we're definitely going to be seeing anterior and posterior syndesmosis from now on, because otherwise we're going to be taking a lot of takes.
Yes.
Okay, so now let's get into the bulk of what today's lecture is going to be about, and that is the Weber classification and the Logge-Hansen classification. These two kind of go hand in hand.
Absolutely. And when we think about Weber, we think about fracture or ligament disruption, and Logge-Hansen, we're thinking about the mechanism of injury. And again, like Dr. Cook said, they go hand in hand. Hopefully this makes it a little bit less confusing and a little bit easier for you guys to remember.
So let's get into it. We're going to start with our Weber classification. This is Weber A, B, and C. The Weber classification is going to be focused around the distal syndesmosis that attaches our distal tibia to our distal fibula. We have our infrasyndesmotic injuries, our transsyndesmotic injuries, and our suprasyndesmotic injuries, which will break up our Weber classification into a Weber type A, our Weber type B, and our Weber type C. When we have a fracture below the syndesmosis, again, that will be like a Weber A or an avulsion injury. If we have a fracture through that syndesmosis, classically like an oblique fracture of our distal fibula, that is a Weber B fracture. And any fracture of our fibula proximal to that would be suprasyndesmotic, and that's going to be a Weber type C. Now we have our Logge-Hansen, which identifies the trauma mechanism, and this goes hand in hand with our Weber classification. So with our Weber A, our Logge-Hansen is a supination adduction mechanism. With our Weber B, this is going to be a supination exorotation. And with our Weber C, the mechanism is going to be a pronation exorotation. There's also a pronation abduction type of mechanism in this area, but to simplify everything, just consider your mechanism for your Weber C's to be a pronation exorotation mechanism of injury.
And a little memory hook you guys can try to do, which I just came up with, but my brain kind of thinks differently, so maybe you're not going to follow along. But A, B, C, SA, 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 SE, P, PE. So A, B, C, SASA-P.
Yeah, I mean, it could help. Maybe it helps, maybe it doesn't. It's a bit confusing for me, but this entire thing is confusing. So next, we are going to go through each of the Weber classification with its associated Logge-Hansen mechanism. We're going to do an animation, then we will do an example. And what we'd also like you to do is maybe with your own ankle, these animations are going to be of a right ankle, or kind of twist your foot around so you can get an appreciation for how this injury mechanism is actually happening. So with the supination adduction, this arrow indicates the force vector or the adduction portion. The supination is going to be highlighted by the tilt of the talus. And remember, supination is that classic rolling of the ankle. And the force vector is going to be medially. Our Logge-Hansen stage 1 is going to be when we either get an avulsion fracture of that distal fibula, which again is going to be infrasyndesmotic. The syndesmosis is highlighted in yellow. So appreciate how the fracture line is below that. Anterior syndesmosis is attached. We could also have disruption of our lateral collateral ligament, which would attach that distal fibula and that talus. And there's just some soft tissue swelling in that area and a gap. Our stage 2 Logge-Hansen is that adduction force, which drives the talus up into the medial malleolus, and it creates that oblique-like fracture.
And knowing that this fracture of the medial malleolus is vertical and more of a oblique shear fracture going up will help us distinguish between Weber A and other types of Weber fractures later on.
Okay, so let's look at an example of a Weber A. This is an avulsion fracture of our distal fibula. When we zoom in, we can see that small fleck of bone there, and we have some associated soft tissue swelling. This is below the level of the syndesmosis, indicating Weber A fracture. So now that we've identified our Weber classification, we can think about the mechanism of injury based on our Logge-Hansen criteria, and then this will help us to identify any further pathology. So now that we have Weber A, I know this is a supination adduction injury. I then bring my focus to the medial malleolus, where there's potentially going to be that shear force and that adduction force up into the medial mal. We study that area. We don't see any fracture of our medial malleolus. So this is going to be a Weber A fracture, stage 1 Logge-Hansen.
So next up is Weber B. So when we're thinking about this mechanism, it's a supination and exorotation. While I'm saying this, you should be supinating your ankle and exorotating it like that, out laterally. With this, our force, or our sum of the forces, is going to be laterally. So that means this talus is then going to go laterally and disrupt that anterior ligament that we talked about before in yellow, and that is stage 1. Stage 2 Logge-Hansen is going to happen kind of at the same time, where we have that oblique fracture of the fibula at the level of the syndesmosis. Stage 3, we're going to then go to our lateral x-ray and look at the posterior aspect of the tibia. This is where we're looking for a posterior malleolus fracture or posterior ligamentous disruption, which in this case we wouldn't see. Lastly, we have stage 4, which is where we get the medial malleolus involvement here. This is going to be a medial malleolus avulsion fracture or rupture of the deltoid ligament, where we can see a widening of that clear space next to the medial malleolus on a mortise view.
Now, a couple of key points as we get into our Weber B and our Weber C. The deeper stage that we get into on the Logge-Hansen criteria, the more severe, more unstable the injury. So if we're appreciating a posterior malleolus fracture, or we are appreciating medial clear space widening or avulsion fractures of our medial malleolus, this is a deeper stage within the Logge-Hansen criteria, and thus this ankle is more unstable. And why that is important is because these types of injuries are more likely going to require surgery and are possibly an indication to obtain a CT scan.
So here right away, I think a monkey could call this some sort of fracture in the ankle, right? So we're looking at these fractures and we're trying to figure out how to classify this unstable ankle fracture. Let's start with our fibula right here. And if you trace this fracture line all the way down, you would see it's transsyndesmotic, which means it's a Weber B. Next thing we need to figure out the Logge-Hansen staging. And since we have a Weber B already, we know this is at least stage 2. But then if you look over here, we have a medial malleolus disruption or avulsion fracture. So automatically, you know it has to be a stage 4, which is not great. If we know it's a stage 4, but we don't know if there's a posterior mal involvement, there has to be a stage 3. So let's look for it on our lateral. If we look for it on our lateral, I don't see any cortical disruption of the posterior malleolus. So there must be some sort of posterior ligamentous disruption instead. There's a ton of soft tissue swelling here in the anterior portion that we talked about earlier, but there's got to be some sort of posterior ligamentous disruption. So all in all, we're going to diagnose this as a Weber B, Logge-Hansen stage 4.
So let's move on to our Weber C and our associated Loggy-Hansen criteria, which is going to be a pronation exorotation mechanism of injury. Our Weber C injuries are going to be suprasyndesmotic. Our Weber Cs are associated with pronation injuries. Our previous Weber A and Weber B were associated with supination injuries. So now our talus is going to be going in the opposite direction. I kind of want you to evert your foot or pronate your foot so you can get an idea of what this mechanism feels like. This is going to be eversion, and then exorotation is that going to be that driving force or where our force vectors are going to be going. And that's going to be highlighted by the arrow. And then you can appreciate the pronation of the talus and the exorotation because that force vector is in the lateral direction into our fibula. So our stage 1 Loggy-Hansen is going to be an avulsion of the medial malleolus. You don't have to have the fracture. That also could just be a deltoid ligament disruption, and then you have medial clear space widening. Now, this is somewhat different from our Weber B, where the medial malleolus involvement was stage 4. Stage 2 is rupture of the anterior syndesmosis. Stage 3 is fracture of the fibula above the level of the syndesmosis. In stage 4, we will bring in our lateral again, and that is going to be rupture of the posterior syndesmosis or avulsion fracture of the posterior malleolus. One thing I want to highlight about both the Weber C and Weber B, when we have posterior malleolus involvement, both of those are later stages of our Loggy-Hansen criteria, thus more severe injuries and more likely to be unstable injuries. Again, if you get that deep into the stage of your Loggy-Hansen criteria, we have to be clued into the severity of that injury and possibly getting our orthopedic colleagues on board faster and possibly obtaining a CT scan.
When you have a posterior malleolus fracture, it's extremely rare to have that as an isolated injury. So you have to be on high alert and really be hunting for these other really subtle, sometimes just ligamentous disruptions that could make this a severely unstable ankle injury.
100%. All right, let's go to our example. This is our Weber C pronation exorotation. We are going to start out with our fracture of the fibula. Immediately, we can see that the fracture is above the level of the syndesmosis. So now we are in Weber C. Based on that, we can now apply our Loggy-Hansen criteria, which is our pronation exorotation. So stage 1, we look at our medial malleolus. We have an avulsion fracture of our medial mal, and then we can also appreciate some subluxation of our talus laterally. And again, this is consistent with the criteria, right? Because those force vectors are going to be exorotation and lateral, driving up into the fibula, and that's why we get that proximal fibular fracture. Our stage 2 is rupture of our anterior syndesmosis. Our stage 3 is that fracture, which is quite obvious here. And then we should be following up with our lateral and really focusing on that posterior malleolus to see if we see any cortical disruptions, which I do not see, but that does not mean that this is not a stage 4. We could still have rupture of that posterior syndesmosis. So at the very least, this is a Weber C fracture, Loggy-Hansen stage 3 or 4.
All right, so next let's harp on the posterior malleolus fracture. Again, typically not isolated. Here is a lateral that looks horrendous. This is our lateral. If you trace your tibial cortice all the way down, you start to get some more hypolucencies in this area, concerning for posterior malleolar fracture. This is actually part of the fibula, which we'll see on this AP view right here. Again, this is our tibia going down this way.
Dusted.
Just a disaster right here.
Just a disaster.
Disaster. This is our fibula completely sheared in half. I guess there's two complete separate, like just split down the middle.
Yeah, and this is actually really cool too, because you might be tempted to call
not so cool, but
or not so cool, exactly. You might be tempted to call this a Weber C, but this is a great example of how you have to trace the origin of that fracture on the fibula. So if you trace it, it actually goes down right to the level of the syndesmosis. So this is a Weber B fracture.
And you also see some cortical disruption or pieces of bone back here, which could be from that posterior malleolus. So I want to talk about a concept that you may have heard actually is more commonly talked about than the Weber classification, and that is bimal versus trimal fractures. So a bimalleolar fracture are fractures at two malleoli. One here is our medial, and here's our lateral. Obviously, we don't have our lateral x-ray here, but I'm telling you there's no posterior malleolus fracture. Here we have our malleolus fracture here and our malleolus fracture here. right here. Obviously, here's the tip of that medial malleolus in this absolute disaster of a ankle x-ray. So take a look at this mortise view and see if you can make the diagnosis. So here we have an obvious fracture through the fibula, which looks to be just above the level of the syndesmosis. So this is supra. So this is probably a Weber C. So let's look for some other things. We see right here, there's no fracture here, but we do see evidence of widening of that medial clear space. And that in itself makes this concerning for a bimalleolar equivalent fracture. And that's because that deltoid ligament is disrupted, which means that the ankle is completely unstable, which is equivalent to a bimalleolar fracture. It's the same exact thing as if there was a fracture through that medial malleolus.
Great point. We are harping on these so much because your bimal equivalent fracture, your bimal fracture, and your trimal fracture, these are things that you're going to hear. You should understand because these are unstable injuries. So with that, let's talk about some unstable injuries. Unstable injuries are injuries that are going to require orthopedic intervention. We are going to start with our first one, which is any talar displacement. Next up, bimal or bimal equivalent trimal fractures. We have our posterior mal fractures with greater than 25% of the posterior mal involved or greater than 2 millimeters of step off. Generally going to need a CT scan in order to identify if that criteria is met or not. Next, we have failure to reduce a displaced ankle fracture. After that, we have our Mason-New fracture. And lastly, any open fracture. And remember, an open fracture is when bone is in contact with air. Be on high alert when you have small puncture wounds because bone might not obviously be outside of body, but sometimes if you get sharp fragments of that bone and they puncture through the skin, that counts as an open fracture. So just be on the lookout for that as well. Okay, we want to highlight our interpretation just one more time. We brought this up in our general approach video, and we want to bring it up one more time here, and hopefully it makes a little bit more sense now. So you are going to start with your first impression. And again, that's going to be initially identifying our Weber classification. After that, we are going to re-examine using our Loggy-Hansen criteria. We're going to try and identify any other subtle injuries, and then we are going to make our final impression. And using this approach will help us from missing any subtle injuries.
Yeah, and again, if we don't do this, we could miss those subtle injuries that actually diagnose an unstable ankle injury as opposed to a stable ankle injury. And with that, let's do one case to bring it all together. So looking at this AP on the left of your screen and the lateral on your right, you guys are going to do your ABC approach, but here we're going to skip right to the Weber classification and Loggy-Hansen. I don't see Weber A, which is infrasyndesmotic, typically a horizontal avulsion fracture or some sort of ligamentous disruption in this area. There could be, I guess, but there's some swelling here, and that's not really indicative of much other than an ankle injury. We also are looking for Weber B, which would be at the level of the syndesmosis and oblique fracture, which I don't see as well. So that only leaves a potential Weber C fracture here. And when you're going through the rest of this AP or mortise, because maybe the patient's in a lot of pain or there's too much swelling to get a true mortise view, you do see that there is medial clear space widening. So that tells us that there is a deltoid ligament disruption, and that would be found in a Weber C. But again, I don't see any suprasyndesmotic injury or any cortical disruption noted. Let's go to the lateral. I don't see any posterior malleolus involvement. Nothing too obvious there. This looks to be well aligned with the talar dome and the tibial plafond. There's definitely some soft tissue swelling here and here and here. So that's kind of our interpretation right now. So after looking at these images, you go to the patient and get a deeper history and physical exam. And on history, you hear that they had a pronation injury and exorotation. So that is the sum of the forces on this patient's ankle. So when we think about that, we then do our physical exam and you see this patient's ankle, it's super swollen. And with this, you should always be palpating the proximal tib fib. And if you did that, you'd probably elicit some pain because they have something called a Mason-New fracture. And that is the translation of those forces from that pronation and exorotation mechanism of injury up the fibula towards the proximal fibula, causing a fracture up there, completing this Weber C fracture. In review, today we went over a lot of very complex topics, and I highly recommend going through this video a few more times and doing a deeper dive into this on your own to learn more about this. We talked about the Weber classification and Lage-Hansen staging. Weber A is an infrasyndesmotic fracture or injury. Lage-Hansen for that would be supination, adduction. Weber B is transsyndesmotic injury. Lage-Hansen there would be supination, exorotation. Weber C is suprasyndesmotic. Lage-Hansen would be pronation, exorotation. Again, my way of remember that is ABC, SASA P. Remember, posterior malleolus fracture that's isolated is extremely rare. So when you see that on an x-ray, think of a more severe injury. If there's one fracture, there's most likely another. Be on the lookout for Mason-New fracture and do a very good history and physical exam on these patients by palpating the proximal tib fib. Unstable injuries need an ortho consult because they may need to go to the OR sooner rather than later, especially if there's neurovascular compromise in these patients. Interpretation strategy should always be your first impression. Then you're going to re-examine those films with the Lage-Hansen mechanism of injury staging in mind, and then give your final impression. Everyone, that is ankle injuries. We will see you in the next video.